The shoulder is made up of three bones, the clavicle, humerus, and scapula. One also needs to note the acromion and the process of the scapula, as well as the sternum and the ligaments that hold these structures together. There are four ligaments one has to know: the sternoclavicular ligament, the acromioclavicular ligament, the coracoclavicular ligament, and the coracoacromial ligament. The three joints of the shoulder are the sternoclavicular joint, the acromioclavicular joint, and the glenohumeral joint. By definition, a shoulder dislocation occurs when the humeral head moves out of the glenoid cavity, disrupting the glenohumeral joint. Shoulder stability is maintained by the joint capsule complex and the negative intra-articular pressures, the glenohumeral ligaments, the rotator cuff muscles, and the intact nerve supply to the rotator cuff muscles. Injury to any of these components may result in shoulder instability or dislocation. Note the location of the inferior glenohumeral ligament here and the axillary nerve and its branches here. The most commonly injured ligament in anterior dislocation is the inferior glenohumeral ligament. Damage to the axillary nerve may result in shoulder instability. Shoulder dislocations may be traumatic or atraumatic. Traumatic causes are due to non-accidental injuries or accidental injuries. Accidental injuries may be sport or non-sport related. Atraumatic causes include congenital causes, cerebral palsy, ligamentous laxity, and axillary nerve dysfunction. The Thomas and Matson classification system is a historical classification system you may hear of when referring to causes of traumatic and atraumatic anterior shoulder dislocation. This system uses two mnemonics, one for traumatic dislocation and the other for atraumatic dislocation. These are TABS and AMBRI, which outline the etiology, pathophysiology, and management. Where TABS stands for traumatic, mechanism with unidirectional instability, where Bankart lesion is the pathology, usually requiring surgery. And AMBRI stands for atraumatic mechanism with multidirectional instability and bilateral involvement for rehabilitation. Inferior capsular shift surgery indicated for failed conservative management. If we link this classification system for anterior dislocation to what we've covered regarding traumatic and atraumatic causes of TABS are thought of as being torn loose, whilst atraumatic causes or AMBRI are thought of being born loose. Shoulder dislocations are broadly categorized into four categories. These categories are based on the location of the humeral head post-dislocation, which may be anterior, which is the most common, posterior, anterior superior, or inferior. We will discuss each of these in a little bit more detail. Anterior dislocations are the most common. These injuries occur due to external rotation and abduction force, which moves the humeral head anteriorly. Patients will present with their arm in external rotation and abduction. Additionally, the acromion may be prominent, posteriorly and laterally, which makes the shoulder appear as a square. This is known as squared shoulder. Given the mechanism of injury of the humeral head moving anteriorly out of the glenoid socket, a Bankart lesion or a Hill-Sachs lesion are recognized complications of anterior dislocations. If we move the humerus a little forward, we can explain this in a little more detail. You'll note when the humeral head moves out of the glenoid socket, it has the potential to cause soft tissue injury to the anterior structures of the glenoid socket. Injury to the glenoid or the labrum is known as a Bankart lesion. Additionally, as the anterior aspect of the glenoid socket interacts with the posterior aspect of the humeral head, the posterior humeral head may get indented. This is known as a Hill-Sachs lesion. This is an anterior superior dislocation. Inferior dislocations are rare. They're also known as laxio erecta. This is a rare dislocation that occurs as a result of hyperabduction. The patient presents with their arm abducted over their head. Should you observe a patient with the following posture, consider this as the diagnosis. Posterior dislocations are less common. The mechanism of injury involves an adduction and internal rotation force to move the humeral head posteriorly. Like in anterior dislocations, there may be an associated Bankart or Hill-Sachs lesion. Let's move the humerus posterior for a better view. Here you see a posterior Bankart lesion and a reverse Hill-Sachs lesion. On X-ray, you'll see what looks like a light bulb in posterior dislocation. This is known as light bulb sign. Clinical assessment. When assessing the shoulder, particularly if there's a history of trauma, apply basic ATLS principles. On examination, you use the look, feel, and move approach. Look for deformities, open wounds, or bruising. Feel for tenderness, crepitus, and do a neurovascular check. On movement, you'll note decreased range of motion. Generally, patients with a shoulder dislocation will be unable to touch the opposite shoulder. All suspected shoulder dislocations should have an AP and lateral X-ray done prior to reduction if possible. For more complicated injuries, one may request a CT scan or MRI. Management. Management of shoulder dislocations include reduction of the shoulder, which may be done non-operatively or operatively. Non-operative management is usually applied to atraumatic lesions, which usually are reduced and managed conservatively with rehab. Although commonly done, current evidence suggests that it is controversial to manage first-time non-professional athletes with an acute and incomplete dislocation non-operatively due to the high rate of recurrence. There are many reduction techniques. Here is an extensive list of some of them in alphabetical order. There is no need to memorize all of these, but you will need to know some of them for clinical practice. Some of the most commonly used or referenced methods are the the Stimpson's maneuver, Hippocratic method, Matson traction, counter-traction maneuver, Milch maneuver, Caucher's maneuver, scapular manipulation, and a few others. They can be broadly classified as being traction, leverage, or scapular manipulation techniques. This is followed by shoulder immobilization or collar and cuff, the duration of which can range from 2 to 6 weeks, depending on the patient factors such as age. Commencement of early range of motion is recommended. Operative management is considered in those with a Bankart lesion, complicated injury, chronic dislocation, recurrent dislocation, and in athletes. Surgery may include various techniques for shoulder stabilization. The goal is to ensure that the shoulder goes back to its anatomically correct place and stays there, whether this is done surgically or non-surgically. For more information and a one-page summary and quizzes on shoulder dislocation, visit 4minimedicine.com.